What are antibiotics for? They're killing bacteria. How do they work? They work two particular ways. What are they? Bactericidal, bacteriostatic. What's the difference? Okay, which one kills? Cidal. Okay, very good. Everyone woke up all of a sudden. Thank you.
We had to read a lot, by the way.
You have to read a lot. Yes, thank you very much, but you should be reading a lot. Just a quick once over, not going to spend a lot of time on this. This is just a physiology of bacteria. There it is. Okay, moving on. As you said, bacteriostatic inhibits the growth, bactericidal kills it. Most bacteria, or most of your antibiotics have a combination effect. A lot of them have bactericidal, or they're specific from one or the other, but most of them have a combined effect where it stops the growth and then it kills them as well. So that it slows the growth down so that the body's own immune system can help and attack this. It kills it when it's too overwhelming for the body to take care of. A good example is if you ever saw Braveheart, and they had the first battle scene, and they're sitting up there, and they have all the guys with their kilts and their swords and all that come running in, and then the English come in, they come running down. William Wallace is our immune system, so to speak. He's coming up and killing off all the bacteria. What's happening? The bacteria is what the English are winning. The bacteria is winning. So what happens is now the cavalry comes from the side and wins the battle. If you've seen that movie, that's an antibiotic. They come in to assist the immune system to kill whatever here. Doesn't replace the immune system, but it helps to overcome the problems that the body is having at the time. Pharmacodynamics, how the thing works, is that it does these particular things. Okay? And if any one of these, any one or combination of these things happen, the cell dies. When you talk about the cell wall, it's kind of like having a balloon. If you poke a hole in the balloon, what happens? It deflates and it's no longer useful. Same thing happens with the cell. Okay? If you inhibit RNA and DNA, it can't replicate. We have natural body defenses. We have age. Most of you are at an age where you can fight off issues within the body without any problem. Nutrition. If you have the immune system, the defenses inside your circulatory system to begin with, you have the ability to fight off. And a lot of you have done this. You wake up, you feel really yucky, you're kind of a little sweaty, and you feel bad, and then by about supper time, you're fine again. Sometimes it's caused by a test. Other times it's caused by something has invaded your body, and your body now is fighting it off. And you get those secondary symptoms because of that action. Resistance, antibacterials. We'll talk about these. We have natural inherited resistance, so you have within your body, either from that you have already. Some people have stronger immune systems than others. We have acquired. We have those which are given by immunization and so forth. We'll cover that. We have nosocomial infection. That's actually a sidebar. Nosocomial infection is nothing more than an infection that happens in the hospital. 90% of the patients with infections in the hospital generally have them from the hospital. There are some that come from the outside that are there, but a lot of them happen within the hospital itself. And for various reasons, not just because we're not washing our hands right, we're not covering our face, but a lot of other reasons happen at the same time. We have antibiotic combinations, and we do that in order to double the effect. One of the most effective ones that women take is called Bactrim for UTI. That's a combination antibiotic that helps get rid of the infection faster, more efficiently. We have them where you have one antibiotic that actually does not do a whole lot, but it makes the other one work harder and more efficiently. And then we have those that you give two at the same time, they beat one another off and nothing happens. And the infection grows and the antibiotic is worthless. Side effects for antibiotics. This is almost across the board. We have rash, pruritus, we have hives. You can also add nausea, vomiting, diarrhea, and abdominal cramps. That is universal for almost every antibiotic within certain extents. For example, penicillin can cause abdominal cramps and can cause a little bit of loose stool, not too much. Amoxicillin, you're pooping all day long. Okay? But these are general that happen with antibiotics. Severe adverse reactions we have are anaphylactic shock and so forth. Most of those things happen because the patient has a sensitivity to antibiotics. Back in the 1940s, they developed penicillin, the drug of the century. Okay, in the 1800s, they developed aspirin. Aspirin was the greatest drug in the world. It cured everything, or so they thought. And then penicillin came along and it said, oh, it cures everything. Got a cough? Have penicillin. I stubbed my toe. Well, have some penicillin. So what's happened is that people within that generation, they were born in the 20s, 30s, and so forth, have been dosed with penicillin so much that they have become allergic to it. And a lot of the older generation, if you look on the chart, it said allergies, penicillin, because of the overuse thereof. And then others, there's some of you who may have allergies and just your body just cannot handle that medication within it. And it rejects it when we have those severe reactions. Yes?
If you're allergic to something as a child, is it feasible to say you wouldn't be as an adult
No.
because you're more of your age? If you're allergic, you're allergic.
Not all the time, but the rule of thumb is if you're allergic as a child, why risk it while you're an adult? So they will avoid that and go someplace. We have so many different kind of antibiotics. You don't have to give them that one. You can give them so many different other kinds. So why risk putting you into harm's way just because the test is you got going?
But you gotta do the next page of
Let them try it later, and I'm like, I don't know.
Well, it depends. It depends. I have had people who had allergy to penicillin, who took penicillin without any problem. And then the next time they had to take it, they had a severe reaction. So, but the rule of thumb is if you have an allergy, avoid it and go someplace else. The treatment, you have antihistamines, epinephrine, bronchodilators. Those are just treating the symptoms that we have up here. Bronchospasm, laryngeal edema, and so forth. These are treatments. So you have epinephrine, we have Benadryl, and then you have different kinds of bronchodilators you can use. That's all I'm going to say. We'll cover those things later. With antibiotics, we have a super infection. As you can see up there, it's a secondary infection where normal flora is killed. What's a usual super infection with antibiotics? Okay, yeast infection is number one. And primarily oral in thrush. But also in urinary tract as well. Okay. And one reason for that is because antibiotics are excreted through the urine. And usually occurred when treated for more than 1 week. So you have this antibiotic on for more than 7 days, usually it comes on. Very rarely do you take one pill and it's happening. It takes a period of time, but it's knocking out the floor. When you have a side effect of diarrhea, that's what's happening is that the antibiotic is killing off the bacteria. That's a normal flora within your intestine. And without the normal flora, they can't stop and process and digest food effectively, and therefore what comes in goes out. Okay. But usually not so severely that we have to limit the antibiotic itself. And then organ toxicity, if you have too much in there, we have ear, and that's really easy. We have ringing in the ears. We could have deafness caused by antibiotics. We have liver, some liver damage can happen, and kidney damage. More kidney than liver because most of the antibiotics are excreted through the kidney, and therefore the kidney has to filter all that stuff out. We have different kinds of spectrum. We have broad spectrum and we have narrow spectrum. And all that is broad spectrum kills everything, gram-negative, gram-positive, kills anything that it comes in contact with. Where a narrow spectrum is set aside for a particular kind of bacteria. When you give us a sample, whether it's urine, blood, whatever else, what they do is they do a thing called culture and sensitivity. You ever seen that? Mm-hmm. The culture is that they rub it on a petri dish, they put it into an oven, basically an incubator, and they watch it grow and see what grows in there. Okay, then they can identify what the bacteria is. The sensitivity is that they have the same petri dish set up, but they have antibiotics that are impregnated. Yeah. Thank you, impregnated. Thank you very much. Throughout that medium, so that what happens is when it's incubated, whatever bacteria does not grow around that particular antibiotic, that's the antibiotic of choice. So a lot of cases, the doctor says, okay, let's put you on a broad spectrum, boom, because you have an infection, boom, we'll get you started. And once the test comes back, they want, oh, okay, we have something more specific, let's get you off of that one and put you on this one because it's going to be more effective against that stuff. Some of you may have experienced that, where they started you on an antibiotic and they change it and you go, what in the world are they trying to do? Yeah, it cost me $80 for this one, now it's costing me $60. Well, that's fine. We'll talk to the doctor and see if they're okay with it. Structure of penicillins, we have what's called a beta-lactam ring. Anyone know what that is?
Isn't it the ring around, like, the cell membrane? It's kind of what makes it up. That's what's broken down. Beta-lactam.
Okay,
I don't know how to describe
that's
it.
good. You did well.
I can draw a picture.
This ring causes the bacteria to be resistant to penicillin or to antibiotics. This makes it resistant to antibiotics. So the antibiotic that's used, they identify it and they say, we have this issue, therefore we are going to give them the antibiotic to be able to destroy this so that the bacteria can be destroyed. Very good. Basically, penicillins, you have, as you see up there, we have the staph infection is number one usage for the penicillins. And then we have different kinds of narrow spectrum penicillins. You'll see these throughout what they'll say penicillin G or so forth, penicillin B, or the specific penicillins. Broad spectrum kills everything. Against gram-negative, gram-positive. If you remember in science class and you had to put the dye on the bacteria and you had to determine if it was pink or purple, well, that's gram-negative, gram-positive. Specific bacteria or that. Okay. And then we have other penicillins, aminopenicillins, amoxicillin and ampicillin, which in a lot of cases tend to be more effective than the basic penicillin itself. That's all I'm going to say at this point. And we have those things which are resistant to penicillins, most gram-positive, staph, and therefore we may go to a specific penicillin to be able to kill this, which is an anti-staphylococcal or anti-staph penicillin, which in this case is doxycycline, like cloxacillin. Questions so far? I'm running through fast, I realize.
Is it more important to remember dicloxacillin or diaminopenicillin?
On the test, if you see one, you'll see the other one in parentheses.
So we should know all the examples that are on there.
Yeah.
But let's say not everything that's in the chapter. Because I know they give multiple, even more examples.
How did I tell you to study?
90%
Use this,
PowerPoint.
and then match it with your text. Keep it simple. We have extended penicillins against gram-negative, things like Pseudomonas, and subsputal pneumonia, and so forth. And this is what they do, and the examples that they have. You will have some antibiotics which can affect almost any organ system. You have other ones which are specific for upper respiratory, urinary, and so forth. We'll hit on those. Like we talked about before, we have combinations that we will give in order to be more effective. So we have medication. One antibiotic, this will be added on another antibiotic. Sometimes they're two given together, or they've already been combined, and then one medication. We talked about already the bacterial beta lactamase, how it's given. Combination intensifies the effects of amoxicillin, and then the examples when we have different kinds of medications here. And we say it's given parenterally. How's it given? IV. And then when you see nursing interventions, there are a number of medications that you want to be careful of how you give it. Like, for example, penicillins work best when you have an empty stomach. When you're not, and then to avoid things like alcohol, and then you can look at monitoring. With the first dose, again, we have a lot of people who have allergies to penicillin, therefore monitoring to make sure you don't have any questions so far? Cephalosporin, we have our beta-lactam structure again, semi-synthetic. Penicillin is generation 1. Generation 1, that was the first antibiotic. And then as they start creating new antibiotics based on the original, we have what's called different generations. You have first generation, second generation, third, fourth, and so forth. This is your second generation. we have them now is we have what, sixth or seventh or eighth generation, and they're all synthetic. Where penicillin was first started off, it was basically plant-based. Where now a lot of these things are grown in a test tube in the lab. Still effective. Still is effective. In some cases, it's good because it can make it stronger or vary the strength in it. The other thing that cannot be good because when you have synthetic, you have to have what's called binders in order to hold it together, and some people have allergies to binders. My mom has no allergies to antibiotics, but they found that she had the allergies to the new synthetic medication based on the binders themselves. Therefore, she has to take regular penicillin. Stuff. Made out of stuff. Kind of like a hot dog. What's a hot dog made out of? Stuff. Okay. And what it's used for. Cephalosporin is a very good medication. If a person has an allergy to penicillin, who knows what the drug of choice is? Erythromycin. Very good. That is the first drug of choice. First drug of choice. This is used to be considered the first drug of choice. However, some people who have allergies to penicillins have allergies to this. That's the only sidebar. So if you have allergy to penicillin and you're giving this medication instead, then you have to watch to see are they going to have an allergic reaction. Or in some cases, the doctor won't even give it in order to avoid that allergic reaction or something else. Because there are a plethora of antibiotics out there. A plethora.
So if you develop the allergy to this, is it because it finally becomes toxic in your system?
No, no. Your body just cannot handle the components of that antibiotic. And it rejects it. And it's, you know, all the severe side effects because it's trying to reject that medication. Generation of cephalosporin, as you have up there, you will not be asked, okay, what's the third generation of cephalosporin? You will not be asked that, but this is the informational slide for you. You won't have to know all these things, but they kind of skim over it anyway. Some of these, one or two of these may pop up. Keflex was a first generation cephalosporin, which was very effective. Very effective. It is still one of the highest effective antibiotics for upper respiratory infection. That's not used a lot anymore. It's still used. The reason I put this, no, you won't have to know this. The reason I put this up is to show that each generation affects bacteria differently, or in similarly, but in a little bit different style. Okay? So you start off with one, you come out to the other one, you become more sophisticated. It's like you started off driving a Yugo. By the time you got here, you're down to a Mercedes. Okay? And then the pharmacokinetics is taken orally. You can be given IM or IV, and the side effects pretty much generally what the other penicillins were, correct? That's a general, still in the same area. The biggest...
What is pruritus?
Itching. It was probably written back in ancient Greece, and they had this guy named Curate, who always would walk around like this, and then someone said, oh, you have itchy skin. We're going to call it pruritus. Okay. Almost everything's named after somebody or something, you know? Drug interaction, Most antibiotics you cannot take with alcohol because alcohol tends to either interfere or degrade the antibiotic itself and/or cause these symptoms. These medications we're assessing for renal. It says up here we have the increased release of cephalosporins. We have an effect on the kidney and on the liver. So general lab tests are given for that. Again, CNS, make sure that that is the medication you want to get. And then administration, you get IV over 30 minutes. Most antibiotics have to be given within 30 minutes to an hour in order for effective within the IV solution state effective. Keep out of reach of children. Don't put your antibiotics in a candy box. My mother. Not sure that. I like how you got that away.
They were wrestling the cat. We could say.
One, come back in 10 minutes rather than 15.